Wow.
So,
Hello.
hello, Mando and
Hmm.
Mitch. I'm back. So,
Hi.
I think now it's 12:30 already, so I think it's time to start the webinar. First of all, I want to thank you for being able to be with us today. I think it's going to be a very interesting webinar, and I'm really looking forward to see what you had to say about children's connecting care for children. I just see that people are starting to really connect now. So I just want to say a few technical things before. There will be a presentation, but also there will be a questions and answer section. So please, if you have any question for the presenter, just try to type it in the chat box that you will see button in your screen, and type there your questions, and we will try to collect them and try to just send them to them. So please just try to type. If you can remind the people also in the middle of the presentation about this, it will be great, because otherwise everybody tend to do it at the end of the presentation and it's a bit messy. So we will try to do it as interactive as possible. So please just go ahead, make questions. And I just want to give you the floor for present yourself, because I think you are better presenting yourself than myself. And well, thank you for it. And well, I give you the floor.
Great. Thank you so much. That's brilliant. My name is Mitch Blair. I'm Professor of Pediatrics and Child Public Health here in London at Imperial College. And I want to introduce my very good colleague and friend, Dr. Mando Watson, who's a specialist general pediatrician here in London, in Northwest London. Just to give a little bit of context, some of you may recall that I presented in Oporto recently on the work of MOCA, the Models of Child Health Appraised in Europe, which is looking at primary care systems in countries in Europe. And we also took the opportunity of sharing that workshop with Antoni Perez from Barcelona, who had a very good example of an integrated primary and specialist care system. Since then, there have been a number of examples, and today I want to introduce our experience here in Northwest London and hand you over to Mando Watson, who's been specializing in a integrated primary care service with specialists for children in Northwest London. So over to Mando.
Lovely. Thank you very much. And it's a real pleasure to be given this opportunity. And I will try and speak slowly and clearly, and I hope, Diana, you'll guide me if necessary. What I suppose I'll do is switch now to the I'll switch now to the slides. And I'm just being told to do what?
Camera off before the slides.
Camera off. Okay, fine. So if we do that and that, I hope you can still hear me. And here we go. So perhaps the first place to start is with a map, given the fact that we're speaking to a European audience. This is a map of England and Wales, and shows where in the country we have had this type of connecting care for children model of care evolve. And we're based in London, and in London we've had probably 2 to 3 years more experience than other parts of the country. And so we've got the opportunity to see what's actually happened when you change the way in which you deliver healthcare for children. This is a map of Northwest London, so a fifth of the London area. The wiggly line along the bottom is the River Thames, and the area of Northwest London is divided into 8 units of healthcare delivery. Because my hospital is based in the southern corner, that's where most of our connecting care for children activity is taking place. And I thought maybe the first thing to do to describe what we're doing is to just give you a little bit of information about the way things are organised in the NHS, in our own health system, because I know it is different from other parts of Europe.
Sorry,
We have.
I don't know if you're going through slides already, but it's just we can just see the first slide with the title.
Oh, okay. We've moved. Yeah, I've shown you some slides. Let's come out and see what's going on.
Okay. Can you maybe close the PowerPoint and open it again?
Sure. So the slides are now open again.
Yeah, we still
and then
freeze in the first slide, I think.
So what about that? Can you see that? That's a map.
No.
Oh.
No. Let me see if I change to my screen, if it's possible.
Go back to the yeah.
Should we do camera?
No, wait.
Okay, let me see. Trying to give you again the right. Are you seeing something in your screen? There it is.
It says.
Okay, so now we can see it again. Try to open again the. Okay, now we can see the map. Yes.
And if I do full screen, can you still see the map?
Yes.
Okay. All right. Hurrah! And I'm going to advance now. I've got another map, a different map. Can you see that?
Sorry. Yes, we can see that. Please go ahead. It's fine. Mando, can you hear me? Mitch? Mando and Mitch, can you hear? Hello, Mando and Mitch? Okay, I can. Hello? Mando, Mitch.
Hello?
Can you hear me?
Yes, now I can hear you.
You see us?
Yeah.
Can you see the slide?
I can see the slides of a map, Northwest London.
Yeah.
Lovely. Good. All right. So I'm going to.
I think that's frozen from before.
Okay, we just need to check that. It is. Right. Well, there. Can you still see a map of Northwest London?
Yeah, it's the same one. I don't know if you changed anything, but it's the same slides.
Now I've gone to a different map.
No, then no. Just try to close it and open it again, but just leave it in a small screen. Like, don't put a full screen.
Okay, so there we are on.
So just keep it. It's when it goes full screen that it freezes.
Can you see us the starting slide now, Diana?
No, I can't see any.
Okay. Oh dear. Are we still on?
Can you reshare the screen with us, please?
Yeah, I would try to give you again the right. Let me see. Okay. There it is. You have again the right. Now I can see your screen.
And can you see the first slide?
I can see the first slide. Just leave it like that if it's better.
Will do. Okay. So the next thing that we were talking about was the sort of geography of the UK and where this sort of model is being developed elsewhere. But we are based in Northwest London, where we have a number of these child health GP hubs. And just really to introduce them, I wanted to explain how the NHS works. We have a system whereby children are looked after, their primary care needs are managed by the GP, the family doctor, and the family doctor does look after children and parents and the whole family without distinction. So we don't have a separate GP or doctor for children in primary care. All of the paediatric services in this country are based in either in hospital, the vast majority are in hospital, where paediatricians will do a mixture of inpatients and outpatients, and a small number of specialist paediatricians are involved with children who have complex disability or severe behavioural conditions. So the model was designed to start to address the gap that we find between the two parts of the system. And in a way, I've deliberately wanted to start with these quotes from patients because we have from the outset wanted to design this around the needs of patients first. So here the first quote, my health visitor told me to do one thing, the hospital told me to do something else. You can imagine.
I think it's still not changing the slides. You're still in the Northwest London.
Oh.
Yeah.
Would it be? Would it work if you ran the slideshow?
I'm gonna try. Let me see.
Okay, and then we can change them.
Okay. Can you see my screen now?
Not yet, but we will do soon.
Supposed
I can see you moving the mouse. Yeah.
Okay.
Yeah.
The model now.
And the next one. That's the slide. Yep.
Okay, there it is. Just tell me next, and I will just pass by the next one.
Just go back one, please, Diana.
Okay, there it is.
So we're starting here. The first quote really illustrates the fact that as patients, if you're hearing different things from different professionals, it's very undermining, it's very confusing. The second quote is really illustrating the fact that if our specialist expertise only sits in the hospital, then patients can't access that specialist expertise until or unless their patients come to the hospital. That's in itself a problem. The third point about a child with disability is the terrible experience that some of these families have when they have a child with complex health needs, where they spend so much time going to multiple different appointments, and the care isn't coordinated and organized in a way that is efficient for the family. The next quote, I think young people need help, is really illustrating the issue that at the moment we tend to do things to patients, we tend to do things to our citizens, and actually there's a huge amount of resource in patients, in citizens, that needs to be released, and part of our model begins to do that. And finally, I think perhaps very importantly, within the UK, where general practice works well, there is a very strong relationship between patients, families, and their family doctor. And that's an asset that we wanted to use. So Diana, do you want to move on to the next slide, which is really an illustration of the three components of the model? And I'll go into each of them in turn, the specialist outreach, the open access, and the public and patient engagement. Because we're looking at the slides in this format, you can see the comment at the bottom as well, which is not a problem, it's quite a good thing. But you might want to put it on full screen actually, Diana, if it is going to be easier for people to see the small lettering. But this is what we have done actually represents a very small shift in the way in which we work, and really is designed to maximize that quality that GPs have, where they are very holistic in their outlook and are able to see the child in the context of the family, the child in the context of their community, and use those aspects to improve healthcare. Okay, so if we go on to the next slide, what I wanted to show with this is the fact that by putting this concept of vertical and horizontal integration, which many of you will be familiar with. But what we have done, I sit in the blue box in the middle called Secondary Care General Pediatrics. But within my hospital, I have a number of subspecialist pediatric services. And because I'm now linked to local GP practices, I'm able to integrate subspecialist tertiary care, secondary care, primary care. And that's a very strong connection. But indeed, by doing that, what we found is that we were also able to generate this horizontal integration, because our GPs are very naturally connected to other parts of the system. Just a reminder to everybody, if they want to ask questions, to use the chat facility. And then I thought maybe the best thing to do to show you the way in which this works, and to take it away from me doing all the talking, is to show you this video. So Diana, on the next slide, there is a link, next one. And if you could go on to that, we'll have a short break from me and watch this video. Oh. Yesterday we tested this and it worked, so I hope it will work again.
Let me try. Looks like today is not working the video either.
Because it's not in the UK.
She tested it yesterday.
Good question.
There are two videos, and I don't know if she tested them both. These things always happen.
Yes, good.
We need some sound. Just need some sound.
No sound.
Diana, do you think you can get some sound? At the moment, everybody is able to hear the words, see the words through the writing, but...
Okay, I'm gonna try, but for me it's sounding perfectly, so I don't know. That's a problem. What is the problem? Let me try it again. Now, are you able to hear?
No.
No.
Does she need to put it to the speaker? Diana, are you on speaker or headphones?
A headphone.
Well, that's why they can't hear.
Diana, what if you used the subtitles option that was at the beginning of the movie?
No, that's not got subtitles. God, it's mad. Right, well, I hope that some of you got the sound, and it happened to be a video which had some subtitles, so I hope some of you were able to follow that through reading as well. I think if you go on to the next slide, Diana, the key message there, I hope you understood, was that we've used a very simple device of taking to get the paediatrician into the GP practice. What we've done is taken the patients that the GPs were referring to the hospital, and instead of seeing them in the hospital, we're putting together a clinic in the GP practice for those patients. So once a month, once every 6 weeks, a general paediatrician will be present in the GP practice, seeing those patients. But what comes from that is the opportunity to come together as a multidisciplinary team and talk about cases. And what I hope you saw in the video is that very nice collaborative atmosphere that it creates, and the fact that we are all learning from each other, and learning as opposed to just service delivery is a very key part of this model of care. So the core of the multidisciplinary team meeting is this triad between the GP, the general paediatrician, and the health visitor. And again, I'm not sure if health visitors are used or are a profession that is present in all European systems. But for those who aren't familiar with the health visitor role, it is a prevention role for young families, so children under the age of 5, involves visiting the home, providing advice on nutrition, on development, on immunizations, and have a very important role in safeguarding and child protection. So at the multidisciplinary team meeting, which happens at the end of the clinic, we discuss the cases that we've seen, and we all learn from that conversation, but we also find ourselves bringing other cases to the discussion. Over time, we've been able in each hub to invite more and more professionals to join this meeting. And if you go on to the next slide, it gives you an idea of how many different professionals are now involved. These what we found in our experience is that the first or second time that say a school nurse attends, they come and they just observe, but by the third visit they will start bringing cases themselves. So the school nurse is a good example where the nurse might be worried about a child who has a health problem and is missing a lot of school. It's a perfect opportunity to try and bring the team together to try and find the best pathway for that child. And once you do that, Diana, move on to the next slide, because what we try and do is encourage individuals to look for cases. So we start moving from a reactive system to one that is proactive. And these are examples. So a midwife might bring cases that he or she is looking after, where there is drug use or domestic violence. And there are some other examples there. We don't need to go through all of them, but I think the important thing is we start thinking about the whole population. And by being present as a hospital doctor in the GP practice, I can move from being reactive and only seeing cases that come to me in the hospital, either through the accident and emergency department or through GP referral. And I become proactive, saying to the GPs, who are the patients in your practice population? What are the children that you're concerned about? How can I help with those? So that brings us to the next slide, which was a piece of work that we've been doing to try and think about child health in a whole population way. And our observation over time has been that sometimes people think about children as child health as one entity, and try and create a system around children, one size fits all. Or they take a particular single condition and try and build a system around that. And really neither of those approaches is efficient or effective across the whole health system. So what we did was think about groups of conditions where you could build a system around that particular group of children or situations. And this is our segmentation model. And I will come back to that in a few minutes with some specific examples, which I think will help to illustrate what we're doing. But if you just move to the next slide, you'll see that there are some cross-cutting themes that need to be taken into account in every single segment of the population. So we feel that with this model, we are actually able to cover and design systems around child health that are effective. Okay, so I'm going to go on to the second part of the model, the open access. So if you go 2 slides forward, Diana, and the point we're making here is that once you have a relationship with a GP, if I'm making face-to-face contact once a month, once every 6 weeks, that GP is much more likely to pick up the phone or email and ask me about cases in between those monthly clinics. This is a nice case example where the GP was worried about a child who may have epilepsy, but as a result of that early contact, we were able to encourage the parents to video an episode and get some more information in anticipation of the specialist visit. But actually, indeed, what happened is that the case moved on very quickly, and because we had very easy contact between the specialist service and primary care, we were able to escalate that case quickly and easily. So that really is an illustration of open access. I want to move on now to the next slide and the one after that, which is to think about how we're doing patient and public engagement. This video may work. If there's no sound, I think we will not watch it because it doesn't have subtitles. But Diane, if you want to have a quick go, it's a very quick, less than a minute video, but it'd be lovely to hear it. Yeah, no. All right, there's no sound. So I think we'll really, this is a lovely mother who has become one of our champions. Let's go back to the slides, Diana, who just talks in the video about being educated. It's very sweet. She says, you know, before I was educated, I used to go to the GP all the time. And in fact, sometimes I'd bypass the GP and go to the emergency department because I just didn't know how to help my child. Now that I'm a champion, I understand the system better and I'm using the system better. And I'm telling my friends and my neighbours how to use the system better. And I think that really illustrates what happened to us, which was that we recognized that if we as professionals changed what we did, but we didn't take the patients with us, then they would carry on doing what they'd always done. It was very important to involve patients in what we were doing. But what has happened is much, much bigger than that. The champions are volunteers. They come from the local community and they are asked if they want to become a part of their GP practice. Do they want to support child health for that GP practice? And they are really keen. Some of them are young adults and some of them are parents, and they come with extraordinary resourcefulness. I'm pretty sure there are people on the forum who understand this, but I would say that many of my colleagues are unaware of the resourcefulness of the community. So the pictures that you can see are of children who are participating in a program we call it the Olympics, because they have found local sports centres, local clubs that will offer activities to children either for free or for a very tiny sum of money. And the children are participate in a program that lasts a few weeks where they try out all of these different activities. And if they do that, they get an opportunity to go to the local football match for free. What this program has done is given children the chance to be much more active, to use activity resources that they wouldn't otherwise have used, to understand nutrition, to understand healthy eating. It was designed by them, it was resourced by them, the whole thing was done without professional input. And it just showed us how much can be done by tapping into the resourcefulness of the community. There's a fabulous video that you're welcome to see if you wanted to understand more about that. But I think it was just a little taster to realize what you can do if you involve patients and give them permission to do the things that they think are important. Okay, I've got a series of slides now, Diana, which we'll try and go through quite quickly, even though they are quite detailed, because I wanted to give a little illustration of each segment. So the first one is a healthy child who very rarely needs to come and see a doctor. But what we do is invite those parents into the practice to participate, either as a champion or in some other way. And it makes them better informed, and they're much more likely to see the GP practice as the best place to take their young child. If you go to the next one, this is a child who's vulnerable. And there we have an example where the GP, the health visitor, and other members of the multidisciplinary team have an easy opportunity to discuss that case. The whole team becomes more confident in the management of these difficult safeguarding issues, and indeed that child gets escalated into the appropriate part of the safeguarding system if there's the opportunity for discussion. The next one is a description of a child who has a complex health need. And again, the discussion at the multidisciplinary team meeting is extremely helpful. And what we do in that situation is we will invite a specialist from the hospital. So for example, if we are looking after a child with diabetes, we'll invite the diabetes nurse specialist to come to the multidisciplinary team meeting and discuss the cases from that practice that have diabetes, so that everybody is better informed. It gives the GPs and the family more confidence in managing the minor illnesses that may not be related to the complex health need. And it has been really effective in supporting transition to adult care. The next one, the long-term conditions, is very similar, but this is a nice example of a mental health issue where actually we have real problems with resource. There's it's very difficult to get a child seen by a mental health professional, but there's a lot that we could do in primary care to support children that's not being done at the moment. And by bringing a mental health professional into that MDT meeting, you start to change that delivery of healthcare. Okay, and the next one is an acutely unwell child who is severely unwell. What we're doing there is starting to take cases of children who've had to be admitted, who have a severe illness, discussing them and describing what happened to the primary care team, starts to give them a bit more knowledge and understanding of these difficult cases and helps them to be upskilled. And finally, the child who is only mildly unwell. And what we have in this country, and I wouldn't be surprised if it's true across Europe, is that families are increasingly coming to the emergency department instead of seeking help from their primary care doctor. They're also not self-managing as much as we would like to. And what we found is that actually these families are desperately worried that their children are going to stop breathing. And actually they can't think of anything else beyond that, even with a mild illness. So we now go into the practices and into community settings and teach basic life support. And with that, we find that parents start to have a bit more confidence and are able to self-manage or know what to do if their child is unwell. So I'm going to pause for a moment, move on to the next slide, please, Diana, and say, if you do have questions, I can see a few have been coming in, please keep them coming. That really is my description of the model. I want to spend a few more minutes now talking about evaluation. And really, evaluation is so important for us, both in terms of understanding what we're doing, but also helping to share what we're doing with colleagues, including all of you. So I'd really be very grateful for your thoughts on how we are evaluating it and what else we could be doing to evaluate. So we have this quadruple aim that many of you will be familiar with. And if we go on, perhaps just to save time, to the first one, patient experience of care, what we have here, Diana, if the next slide, is some lovely qualitative data. And we have feedback from both parents and young people who feel so much more comfortable being seen in a setting that's more familiar to them. And they feel that their practice, their own GP, has something that is special, which means that they are much more likely to take their child to see their GP, having experienced this type of contact in the GP practice. Moving on, the second of the quadruple aim is reducing per capita cost. And this is a slide that describes the conventional approach, which may be different in the rest of Europe, but I suspect there are elements that are similar. You can see a great long series of processes that has to happen before a child gets seen in a hospital through a conventional outpatient referral. If I'm seeing the child in the GP practice, most of those processes can disappear. And as you can see, there are only two of those processes that actually add value. So we're moving towards a system that intrinsically is more efficient. But if you look at the next slide, we've got some lovely data that shows that it really has been more efficient. Diana, if you move on to the next slide, this is data that we've published, which shows that we were able to reverse the year-on-year trend to ever more hospital outpatient appointments. So the blue bars represent hospital clinics, and these are new outpatient referrals, not follow-ups. We started running our hubs in the beginning of 2013. Sorry, in the beginning of 2014. So you can see there's a tiny amount of brown activity in 13-14. These are children who started to be seen in the GP practice and not at the hospital. By 14-15, we had fully fledged hubs. And there you can see that a larger number of children were being seen in the GP practice, a bigger brown bar, sorry, but the blue bar has shrunk dramatically. And there are a large number of children who no longer need to be seen by a paediatrician, neither in the hospital nor in the GP practice. This is, we think, because more patients are being managed by their GP with confidence, and more patients are self-managing. And actually the next slide shows you how that translates into a very significant saving to the health economy. So our actual observed reduction is in the top left corner, 39% reduction in outpatients, 22% in A&E, and 17% reduction in admissions. We put a very conservative a model in of 38 and 2, and you start to see some very substantial savings. This is not a model that you can introduce overnight. So in our in the bottom chart, you can see what would happen if you had 2 hubs running in the first year, 8 in the second year, 16 in the third year, and so on. That's the second column of the chart. As you get bigger, you have some economies of scale. Some of the coordination costs are fixed. So actually you start to see a net economic benefit, which is on the far right column, which amounts to hundreds of thousands of pounds, if not 6 figures. So if you go on to the next slide, the third of the quadruple aims is around workforce development, and this is a slide again with some qualitative data on how much everybody is learning through this model. And then finally, I wanted to go on, and if you go 2 slides, please, or that slide, please, Diana, yeah, is to think about how we can really evaluate what's happening. On the left, you can see the quadruple aim. On the right, you can see the model. What we're actually putting into the system is interprofessional support in education and patient support in education. And then if you go on to the next slide, we try to answer, what is it that we're actually providing? And we're trying to measure the things in the middle, because we feel that will demonstrate that the model is actually the reason why quality of care has gone up, capita costs have gone down. So if you look at the middle column, we believe that we are increasing knowledge about services, more signposting. We are developing connections and relationships. We're increasing capability both for professionals and for parents. We're taking a whole population, you don't have control, whole population, we're taking a whole population approach, which means that it's much more of a preventative focus and not a reactive focus. And we're focusing on what really matters to patients. So actually, in terms of what we've learned and what we feel others should take from this, Diana, if you go on to the penultimate slide, we have put together these design principles. Actually, there are lots of different ways of doing this, but if you focus on these 7 design principles, and I don't know which one is the most important. I sometimes think the first one is, sometimes I think the last one is, but I think they are all really important. Then actually you have the possibility of achieving some very, very significant improvements to child health. Okay, if we go on to the final slide, I think we'll just leave that there and very much hope that we can have an opportunity for questions and discussion. Diana, back to you.
Yes, thank you, Mando and Mitch. I think it has been a great presentation, and I think there are quite some questions already. The problem now is like the technical stuff. I'm not able actually to see quite good or to just collect all the questions to post it big for you. So
I have managed to do that, Diana.
Oh, you have. Oh, thank you, Mitch,
Yeah.
so much. That will help so much.
We could start if you like. There are about 5 things, yeah?
Yeah.
But Peter Groningen asked about the pediatricians, primary care pediatricians versus general practitioners story. As you know, in Europe, there's a huge variation of practice. And we have just completed a meta-analysis and a systematic review of GP versus primary care pediatrician delivered services. There are extremely small differences between the two in terms of health outcome measures such as immunization uptake, chronic care and unscheduled care for chronic conditions, and early detection of autism and ADHD. And it would appear that these are very small differences indeed. I don't know if that completely answers the question, but we're certainly very aware of those two, that tension between the two professions. There's another question about whether this is only for children. Well, it doesn't have to be. I think there's some very good examples in Slovenia and elsewhere, and in Portugal, where in fact this has been across all age groups, this idea of integrated care. Peter asked about incentivization for connection. So is there a financial incentivization for people to connect together, to work together? In this particular instance, the financial incentivization, I will pass over to Mando. There's no specific incentivization.
No, I mean, this is an evolution. Where we will end up, I am sure, is a redistribution, so that that money that was saved, which I showed you in that financial economic modeling slide, will be reinvested to support this way of working. So there will be an additional premium for me to see the patient in the GP practice rather than in the hospital, and for me to be contributing to those MDT discussions. Likewise, the GPs will be incentivized financially to do this. At the moment, that is unstructured. We're exploring ways of doing it within a very system, an NHS system that's very slow to change.
Another question about conditions for implementation of the program in different healthcare systems. So how do we implement this model in different healthcare systems?
So I wonder if the answer to that is in those design principles. I think if we really think about how we create a system that means that different clinicians from different backgrounds are talking to each other and sharing knowledge, and by learning and discussing cases, it becomes very real, very effective, whereas sitting in a classroom is a different activity that has less of an impact. So I think that would apply to any health system. And I think the other thing I would say in that same context is trying to do it as early as possible. I've been doing this really over about 15 years. Started very slow and in a very tiny scale. But I started doing it with my most senior trainees, people who'd been in pediatrics for 6, 7 or 8 years. We're now doing it with people who have been in pediatrics for 10 days. And actually they are very capable of developing and learning, even when they're very in the system, when they're very new. And I think if we can start early, we have the potential to change the future.
Another question, will hospitals accept money being moved away from their budget? A very interesting issue about the business model that supports integrated care. One that we're still
Sorry,
tackling.
I was trying to read the question.
Right. So the question is, will hospitals accept money being moved away from their budget?
Yeah, I mean, I think that hospitals struggle with this. The reality is that if we are in a health system that is so financially constrained, we should be using the hospital budget for things that really need to come to hospital, and we should be using primary care for things that can be managed in primary care. And over time, we are moving in that direction. And I think that hospitals have no choice but to adapt. You can't continue seeing simple things in hospital just to prop yourself up. What you have to do is acknowledge that if you're only seeing the complex cases, you need more money to do that. And those are the very difficult conversations we're having at the moment.
Selection of patients for integrated care. Mando, how are the patients selected?
Oh, I love that question, because the answer is don't select anybody. Everybody is in the system. It is that whole population approach. And if you can just redirect specialist pediatrics to support children, every child, in whatever way is needed. Sometimes it's just a phone call, sometimes it's a workshop to teach, something around immunizations. It depends what it is that group of the population needs. But I think specialist pediatrics has something to offer for everybody.
And how do you stop the specialists from taking over primary care?
Oh, the whole point of this is to use the best bit, to amplify the best bits of the system. So when a really good GP in a really good practice is connected to a really good pediatrician and a really good service, you have the ultimate system. So family doctors have a huge amount to offer. I, as a pediatrician, cannot possibly deliver the equivalent care of a GP. It's different, and that's an advantage.
And then the practice champion role is a good question about the how do you choose the activities? How do the activities within the community get chosen and selected? That's from Casa.
Thank you for that lovely question. We do try very hard to encourage the families, the citizens, to choose their activities. And what's been utterly special has been to see that they come up with priorities that we would have chosen if we had a choice. So mental health, obesity, nutrition, these are all things that we would have hoped they would choose, but they've done it, and it has to be owned by them. It has to be their initiative. So we're just there to facilitate and encourage, and just frankly, just to give permission.
One of the biggest areas for us has been in the area, certainly locally in London, has been dental health and dental caries, which are very high rates here, with very high rates of extraction, dental extraction and operations. So that is one of the topics that's been particularly important and selected by the champions themselves. A very good question about evaluation and what methods we use to evaluate. If this is precisely why Mando showed this action effect diagram, this logic model, and we are using a mixture of quantitative, as you've seen, and qualitative methods to evaluate the perspectives from the practitioner, from the health system itself, from the economic perspectives, to help inform, I think, a more holistic evaluation of these particular elements of the model, and which are important, which are most important. Diana, I think I've covered most of the questions. I think
I think so too.
Grandparents.
I'm just gonna check, but yeah.
I think self-care and grandparents, very interesting question there about lack of self-management in parents, perhaps as a result of smaller families and lack of experience with grandparents.
I think that's absolutely right, isn't it? And that's, in a way, what we're doing with our champions is trying to compensate for that demographic change where, particularly in London, the sort of community support network has disappeared. And unfortunately, A&E has turned into our community support network. It's terrible. So by reinvigorating community and enabling them to look after themselves better, we're getting a bit of that back.
And your role must have changed, Manda, over the years. So that's another question that's been put. How does the role of the paediatrician actually changed from a traditional hospital sort of centric role to one that's more community outfacing?
Yeah, I think that it does involve coming outside of your comfort zone. Many of us have been, only based in hospitals for years. And it takes a little bit of courage to step outside the hospital. But most of my colleagues find that once they've started, it makes so much sense that they wouldn't want to go back to a service that's just based in the hospital. One of the first things I now do on my ward round when I'm looking after a patient on the ward is to look and see which is the GP. And immediately I'm thinking, okay, I'm going to phone that GP. I'm going to discuss this case with them. It's a very different dynamic.
Another question from Sally about hard to reach families, those that are not easy to engage, such as the Roma community in Europe or other vulnerable groups. How do we?
So our practice champion model is lifted from a very big initiative in Leeds called Altogether Better. And the person who set up Altogether Better said, what do you mean hard to reach community? There is no hard to reach community. If you want to reach a traveling family, go and visit them in their caravan. And so just that question, I think that is the benefit of being away from the centre. It's the benefit of doing things with patients and with citizens. You start actually being able to access everybody.
Diana, I think we've tackled most of the questions that were asked there. I don't know if people want to come back. We've got about 4 minutes left.
Yes, I think we basically tackle everything. So I think we should finish. This has been already a lot of questions for Amanda and for you, but I think we basically cover everything. So I just want to thank you for the webinar and to make actually the work easier because of the technical problems. I'm sorry for that, but I think I think it were really interesting questions, and I think they were very happy with your answers too. But of course, thanks for providing also your contact details, because if anyone wants to make you question, I hope they reach to you, because I think it's a very good model and hopefully it's transferable to other places, which hopefully it happens. And just, well, thank you. Thank you also all the attendants, and thank you all for the questions. And I just want to finish with the slides of our conference, because we also have a conference and hopefully you're able to come, both of you, which it will be actually very interesting to have you there.
While you're looking for it, just to say thank you very much for the invitation. It's been a real pleasure sharing our insights with everybody, and I really would love to hear from people after this forum.
Okay, yeah. That's great. Definitely, we're gonna try to reach you and keep knowing and learning about primary care in children. But thank you so much to both of you, and well, hopefully see you soon, or hopefully see you in Crete.
Thank you.
That would be lovely. Thank you.
Thank you.